Sayonara and Namaste. I'm Aniket Rali from Vanderbilt University in Nashville, Tennessee, in the United States. And thank you for this invitation to share with you a brief discussion on medications that may come in handy in emergent situations. Over the next few slides, we will be talking about what these emergent needs may be that we may face in clinical medicine. We will review what are the different vasoactive options available to us, their mechanisms of action, what are certain clinical considerations that we must take into account while using them, and ultimately leave you with a few useful algorithms that you may find helpful in deciding which medications to use, how to use them, and when to change to a different medication. So the first question that arises is that why do we need these emergent medications? We may need these emergent medications under conditions where the heart rate is too slow. We may need it if the heart rate is too fast, if the heart rhythm is life-threatening, if the blood pressure is too low, or if the blood pressure is too high. But the first question that we must ask under all of these emergent conditions is that does the patient have a palpable pulse? Because the algorithm for how we approach these circumstances and these situations changes dramatically if you have a pulse versus if you do not. So for the first half of the conversation this evening, we will be talking about conditions in which you do have a pulse. We will start with bradycardia. Bradycardia is often defined as a heart rate less than 60 beats per minute. The first question that you must ask when you have a patient that is bradycardic and has a pulse, a palpable pulse that is that what is the rhythm? Are you working with a sinus rhythm? It could be sinus bradycardia. It could be a sinus pause where the sinus node is not firing every once in a while. Or it could be sick sinus syndrome where the sinus node is diseased and does not beat regularly. If it is not sinus rhythm, is it an ectopic rhythm? Is it a rhythm that is originating from some part of the atria but not the sinus node? And ultimately, is there heart block that the sinus node and the atria are firing normally, but because of a heart block at the level of the AV node, you're not able to conduct into the ventricle? Once again, the most important question to ask is the patient symptomatic with this, or is the patient hemodynamically unstable with this? Because that gives us a sense of urgency to act on it faster rather than later. And second, is there a reversible cause to this rhythm? Because if there is a reversible cause, no matter what we do to treat it, it's not gonna resolve until the reversible cause is addressed. The first medication in treatment of bradycardia that I would like to go over is a medication called atropine. This medication blocks the action of the acetylcholine at the parasympathetic sites. In other words, it is a vagolytic drug. It minimizes the effects of the parasympathetic nervous system and the vagal nerve system. As you can see in this cartoon graphic, the atropine works by inhibiting the activation of the parasympathetic system. It is generally administered as a 1 milligram bolus to be given as the first dose, and then it can be repeated every 3 to 5 minutes for a maximum of 3 doses or a maximum dose of 3 milligrams. Some special considerations to take into account when using atropine is that because it relies on intact nervation of the heart, it is not effective in transplanted hearts that are denerved. If you do not have vagus nerve going into the heart, then this medication that works on the vagus nerve becomes less effective. It is also a medication that crosses the placenta, and hence we must be very careful in using it in patients that are pregnant because it may cross the placenta and may cause arrhythmias in the unborn child. The next medication to review is dopamine. As you will see in some of these cartoons that I have put together for a clear demonstration of where do these medications work, what are the specific effects of these medications, and what are some of the doses that we work with. For the dopamine, you want to think of it in two different categories. The dopamine works slightly differently when you give it as a low dose, and at low dose, it causes more of a heart rate to go up. It causes more of the contraction of the heart to be stronger. And on the back end, and those are the mechanisms that it partakes in through its beta receptor effects, but it also has effects on the dopaminergic receptors where it causes vasodilation on the kidneys and in the gut circulation. The same dopamine, when you use it at a higher dose, it becomes even more even more powerful in treating your hypotension. But most of the actions of high dose dopamine are at the level of the alpha receptor, which means that it does not do as good when it comes to increasing the heart rate or increasing the squeeze of the heart. So at lower doses, that's where you get the maximum benefit as far as your bradycardia treatment is concerned, as far as your treatment of heart failure is concerned. And then it's the higher doses where it works as a vasopressor, where if you're dealing with a patient that is hypotensive, then it becomes beneficial to use that. Another medication that all of us are familiar with is adrenaline or epinephrine. This is an excellent medication that is to be used in emergent situations. We know we can use it in patients that are in septic shock. We know that we use it in patients that have anaphylaxis. And we know we use it in patients that have cardiac arrest and you are trying to resuscitate them. So it's part of the ACLS algorithm. And the reason why it has so many different indications and uses is because it works very broadly. It works on your alpha 1 receptors where it increases your blood pressure. It also works on your beta 1 receptors where it increases your heart rate and your cardiac output. Hence, it is important to know that this medication, while it works in different indications, it has different doses that are to be given in different circumstances. For example, if you're giving this medication to somebody in an emergent situation where they have anaphylaxis or a status asthmaticus episode, then you give them 0.3 milligrams intramuscularly. Or if you're going to give them through the IV, you give them 1 milligram per ml. Similarly, if you're going to use this in a code situation where you're coding somebody, where you're trying to resuscitate somebody, then the dose is generally 1 milligrams every 3 to 5 minutes. If you're going to use it in a patient that is in a shock state, be it from bradycardia or hypertension, generally we will start epinephrine at 2 micrograms per minute. Here's a nice algorithm to take into account when treating somebody, encountering a patient in a critical care setting that has bradycardia. Now, once again, keep in mind that these are all algorithms over the next few slides that we will discuss for patients that do have an arrhythmia at this time of bradycardia, but have a palpable pulse. As soon as you lose a pulse, the algorithm changes to ACLS. So in this particular instance, when you encounter somebody with persistent bradycardia, you want to ask yourself, is this causing hypertension? Is this causing augmentation? Are there signs of hypoperfusion in the form of shock? Is there any ischemic chest discomfort because the heart's not getting enough blood? Is there any heart failure? If the answer is no, in other words, it is asymptomatic and hemodynamically stable bradycardia, then you just monitor and observe. If there are any reversible causes that can be reversed, then you work on those. The answer to any one of these questions is a yes. In other words, if it is symptomatic bradycardia, then the algorithm changes. Then all of a sudden, you want to think about the atropine medication that we just discussed. If atropine doesn't work, then you want to start thinking about dopamine. You want to start thinking about epinephrine. You want to start thinking about transcutaneously pacing them. These are the patients that you would put pads on and start pacing them externally. And if any of these do not work, or if you're needing it, then consider getting a cardiologist to come see the patient, somebody who can put in a transvenous pacing so that we can stabilize the patient. That's the discussion on bradycardia. What about tachycardia, the exact opposite problem, where the heartbeat is too fast, the heart rate is greater than 100 beats per minute? The first question you want to ask when you encounter a patient with tachycardia who has a pulse is that, is this tachyarrhythmia? What is the QRS duration in it on an EKG? Is it a wide tachyarrhythmia or is it a narrow complex tachyarrhythmia? Narrow is defined as something that is less than 120 milliseconds. If it's greater than or equal to 120 milliseconds, then it's considered wide. The reason why it is important to make this distinction is because our treatment algorithm for narrow complex and wide complex is slightly different. Once again, just like the bradycardia algorithm, the number one question you want to ask is this patient symptomatic or is this patient unstable from a hemodynamic standpoint? And again, if there are any reversible causes, be it hypokalemia, be it hyperkalemia, be it hypocalcemia, any reversible causes that is driving this tachycardia, then we want to work aggressively at resolving these reversible causes. In this treatment algorithm of tachyarrhythmia, the first drug that I want you to consider is adenosine. This is a medication that slows down the conduction through the AV node. Because it works at the level of the AV node, one can imagine that it is an effective medication against arrhythmias that utilize the AV node for conduction, such as an SVT, and any kind of supraventricular tachycardia that only gets to the ventricles through the pathway of the AV node. It is also effective in treating AV-NRT, which is AV nodal reentrant tachycardia, which forms a reentrant circuit and keeps going in this circular fashion around the AV node. When you give this medication that blocks that, it can break that circuit and get you out of that arrhythmia. The first dose of adenosine is generally given in the form of IV, and it's 6 milligrams that are given. The repeat dose that you can give a few minutes later is generally 12 milligrams. It's a very, very short acting medication. And that's why when you inject this medication, you almost always have to follow it up with an IV flush. And what I recommend is that when you're giving adenosine, that's going to cause the AV node to block and the heart to go into a standstill for a very brief second. It's important in resetting the cycle and it's important in resetting the rhythm, but oftentimes pushing this medication also allows you to identify what that tachyarrhythmia was when you see that rhythm come back. And for those reasons, you want to have continuous EKG monitoring as you are pushing this medication. And just to be on the safe side, you always want to have pacing pads on when you deliver this medication. What are some of the patient-specific characteristics of these medications where you have to be careful or you want to be cautious in administering it into certain patients? So the first thing to consider is that in transplanted hearts, which are denerved heart, because they do not have the sympathetic nervous system attaching into the heart to kind of rebound from stopping of this AV node, sometimes the adenosine can have an exaggerated response. In other words, you can block the AV node for an extended period of time because you do not have that backup sympathetic nervation there to counteract the adenosine. As you can imagine, it is also not effective in ventricular tachycardia because ventricular tachycardia originates in the ventricles and does not rely on the AV node. Once again, important to make the distinction that your tachycardia is narrow complex, i.e., in other words, originating from the atria, or is it wide complex and originating from the ventricle? Another special consideration in the utilization of adenosine is that you have to be extremely careful in using this in AFib patients with WPW where they have an accessory pathway. So when you have a young patient that is coming in with AFib and tachycardia and that looks wide complex, there's always that risk that they may have Wolff-Parkinson-White syndrome and this accessory pathway. Now you can imagine this accessory pathway, this additional highway through which conduction can come from the atria into the ventricle. If that is allowed to operate and the AV node is blocked and all the conduction goes through this pathway, you could technically put these patients into VFib arrest by giving this medication. That's why if you ever have a young patient that has an AFib rhythm or an unorganized rhythm that is very chaotic looking on the EKG or on the telemetry monitoring, and it looks wide complex, you always want to have this in the back of your mind and be very careful giving adenosine. So how do we treat medications, or what medications do we have in treating tachyarrhythmia that is indeed wide complex? And when I say wide complex, I'm referring broadly to ones that originate in the ventricle. There can be supraventricular wide complex tachycardias too, in which case they are originating from the atria, but by the time they make it into the ventricle and they propagate into the ventricle because of some bundle branch blocks, conduction deficits, they become wide complex. But in this slide, we'll be talking more so about stable wide complex tachycardia. In other words, what do you do in patients that have ventricular tachycardia? The first medication that you want to have ready is procainamide. You want to give it at either 20 or 50 milligrams per minute. And the maximum dose that you can give somebody is 17 milligrams per kilograms of their body weight. Another medication that is extremely helpful is amiodarone. You can give amiodarone as a 150 milligram bolus over 10 minutes, and then you can start them on a drip where for the first 6 hours, you give them 1 milligram per minute. Another medication that works really well is sotalol. Sotalol is also a class 3 antiarrhythmic and also has some beta blockade properties as well. And this medication, you give 100 milligrams over 5 minutes. Again, tachycardia with a pulse. the algorithm is different than when you have tachycardia without a pulse. And just like the algorithm for bradycardia, the first question you want to ask is this patient symptomatic? Is there hypotension? Is there shock? Is there heart failure? Is there altered mentation? If so, you want to shock them out of that rhythm. So you give them some sedation so that the shocking process uh, is less painful. And then you can, if it's narrow complex coming from the top chamber and relying on the AV node, you can consider giving a dose of adenosine. And if that doesn't work, you just do a cardioversion. You just shock them, give them external cardioversion, and get them into normal rhythm. If it is indeed not symptomatic, but if it is wide complex, where the QRS is greater than 120 milliseconds, then you consider the same exact algorithm as you would have for persistent tachyarrhythmias that are symptomatic. If the wide complex is narrow and they're not symptomatic, then you have a little bit more time. So in these circumstances, what you can do is you can try vagal maneuvers, like asking them to bear down. Tell the patients, bear down as if you are having a bowel movement. You ask them to hold their breath. You can do a carotid massage. If that doesn't work, you can give them a beta blocker. You can give them a calcium channel blocker. You can give them adenosine to see if you can break that. And in all of these circumstances, you want to have an expert be consulting on this patient to help you out. What if the bradycardia or the tachycardia is pulseless? Then it's a completely different ballgame. Then the paradigm of how we treat these patients completely shifts. This is a very busy slide that shows you the entire algorithm of how to run adult cardiac arrest algorithm that has been published by the American Heart Association. But long story short, in this algorithm, what is important to recognize is that it relies heavily on chest compressions. It relies on identifying whether it's a shockable rhythm, as you can see on the left, or if it is a non-shockable rhythm. Under both circumstances, you give patients epinephrine as your medication. And if it is indeed a shockable rhythm, you could consider giving them amiodarone, or you could consider giving them lidocaine. And the dosing of the lidocaine is what I have added to this algorithm under bullet point 8, where you can see that the first dose should be 1 to 1.5 milligram per kilogram, and the second dose should be 0.5 to 0.75 milligram per kilogram. What do you do if the patient's blood pressure is too low? Usually we aim for a mean arterial pressure greater than 65 in critically ill patients. Some considerations. Coronary arteries are perfused in diastole, except the right coronary artery, which is perfused in both systole and diastole. Hence, when it comes to coronary perfusion, we pay attention to the diastolic pressure. The cerebral baroreceptors are more sensitive to the systolic blood pressure. That's why when you're talking about patients that have poor mentation or may have a stroke, it is important to maintain adequate systolic blood pressure. And then the mean arterial pressure is the best target to ensure adequate renal perfusion. We have several medications that can help. We will not go into all of the details of these medications, but I'm sure all of you recognize these medications from clinical practice. So the first one, the first super power that we have in the ICU in treating these patients, or the first Avenger, is norepinephrine, Levophed. It is a medication that works on both beta and alpha receptors, causes vasoconstriction, and can also cause your heart rate to go up. It is the first line medication to be given in septic shock, in cardiogenic shock, and in neurogenic shock. And generally, you start this medication at 2 to 5 micrograms per minute and titrate up to a maximum dose of 20 micrograms per minute. The second medication, which is a pure alpha agonist, is phenylephrine. This does not change the heart rate. It causes vasoconstriction, and that's how it helps hypotension. This is a medication that is started at 20 micrograms per minute and can be up titrated all the way to 200 micrograms per minute. A medication that is the best friend of Levophed or norepinephrine is vasopressin. This is a medication that works on the vasopressin receptors. And this is a medication that, although you could start at 0.01 or 0.04 units per minute, in my clinical practice, I either turn it on or I turn it off. I do not titrate this medication. And when I turn it on, I almost always put it at 0.04 to help the actions of norepinephrine. While you can have hypotension, and that is a bad thing, on the flip side, you can also have hypertension. We will not go into all the details, but up here, I have provided you an exhaustive list of all the medications that can be given through the IV and in an acute setting to lower a patient's blood pressure. I have also explained up here the onset of action, how long does it take before it takes effect, and then when you leave it on, how long of a duration does it last in the system for. So what are some of the take-home points in treating and using these emergent medications in the critical care setting? First and foremost, you want to identify and treat every reversible cause of whatever problem you're having: slow heart rate, fast heart rate, low blood pressure, high blood pressure. Recognizing the hemodynamic and the clinical instability early on in the disease process is the key, because your treatment algorithm changes whether the patient is clinically stable or they're unstable. Always differentiate in patients that have tachycardia, whether it is a wide complex tachycardia that may be originating from the ventricles, or it's a narrow complex tachycardia that is coming from the atria. And the reason why this distinction is important is because you treat them differently. Then you choose a drug based on the mechanism of action. Are you going for something that increases the squeeze of the myocardium, or in other words, is an inotrope? Are you going for something that increases the heart rate, or in other words, is chronotrope? Are you looking for something that is purely an antiarrhythmic drug, such as amiodarone? Are you looking for something that increases your blood pressure, such as vasopressor? An important point to remember up here is that a lot of these medications are going to have more than one function, and it is important to know what are the different functions of these medications. And ultimately, as you're choosing the medication and matching them to the appropriate patient, it is important to keep these certain considerations in mind that we discuss when it comes to using these medications in special populations. And those are all the slides that I have. Thank you for your attention, and thank you for this opportunity to be discussing these things with you.